So let's move with get on with the finishing up the tularemia. I told you the most common form of tularemia is ulceroglandular, and the symptoms are local ulceration and cellulitis. Cellulitis is inflammation of the muscles. Okay, local ulceration and cellulitis. Lymphadenopathy, the organism can survive intracellularly. It does localize in the cell, inside the cell, within the phagocytes. And when we come to pathogenesis and pathogenic mechanism, I'll tell you why it survives inside the cells. And as a result, it causes lymphadenopathy. So it's ulceration, local ulceration, and lymphadenopathy. After the local infection and ulceration, the organism can spread and does spread into the blood circulation. And when it's in the blood circulation, I already emphasized and pointed to the fact that whenever there are organisms in the blood circulation, there will be fever because they interact with the different cells and produce pathogenic factors. And once it is in circulation, it will localize in different lymph nodes systemically, and therefore there will be systemic disseminated lymphadenopathy. Okay, so that's the symptoms of ulceroglandular, the most common form of tularemia. Here is it's primary lesions. It has got papules and redness and not so much swelling. Papular lesion, as you can see here. Okay, that's obviously a skin lesion. Indolent ulceration and eschar. Eschar is discoloring of the skin around it. Okay. And here is the example, sort of bluish tinge to it. Okay, cellulitis, inflammation of the muscles, and lymphadenopathy, regional. Okay, then typhoidal. Typhoidal is via ingestion, and the symptoms will be gastroenteritis, of course, and then if there is ulceration, if the organism is producing an ulcer, that there will be ulcer as well in the GI tract. It is accompanied by chills and fever, often diarrhea and vomiting because it's in the GI system, and that's the typical symptoms of typhoid as well. That's why it's called typhoidal tularemia. That is by ingestion. Ingestion of meat that is contaminated with, it could be killed, a rabbit, any thing that is hunted, and that the flesh has the organism, and if it is not cooked properly, obviously, or is handling it and then hand-to-mouth contamination. Pneumonic tularemia, the most dangerous form, most lethal form, is the pulmonary or pneumonic tularemia. May follow ulceroglandular. In other words, it may spread from ulceroglandular to becoming pneumonic. You can get pneumonic directly as well. As I was telling you, example that in Martha's Vineyard, the Nantucket Island, I think it is, that's where it is, northeast, there was a case reported that, the lawn mowing or curbside grass mowing led to aerosolization and inhalation, and the guy got pneumonic tularemia. Can be acquired directly by respiratory route. That's what I just emphasized. Very few organisms will cause this form of disease. 1 to 10, as few as 1 to 10. And obviously that is why this organism is one of the bacteria on top of the bioterrorism list. Okay? The other one is anthrax that we will talk about in a little while. Okay? Okay, peribronchial infiltrates, pleural effusion. That's not unexpected. Here is the X-ray. Nothing atypical of different from some other infections. It has a very, very high mortality, about 30% untreated, and even treated when treated, it could be as much as 5 to 10%. Okay, there are the other clinical forms that I mentioned to you. They are very, very rare, especially oculoglandular, and in which case there's painful purulent conjunctivitis, conjunctival ulceration. Again, the same thing. That's what you would expect from tularemia, Francisella tularensis infection. Regional lymphadenopathy, again, because from there it will go to the regional lymph nodes and cause swelling and inflammation of lymph nodes, and those would be the symptoms. And the even more uncommon is oropharyngeal. What it really means is that the contact through the mouth, hands to mouth, or some other way, and it doesn't get into gastric area, okay, further down the intestinal canal. So instead of typhoidal, if it harbors itself in the just oropharynx, then it will cause lesion there. Exudative pharyngitis and tonsillitis are consequence of that kind of infection. And as I said, very, very rare that form is, because usually when you're eating it will go either typhoidal or not at all. Even typhoidal is uncommon. Treatment is difficult because the organism is intracellular, just like any other intracellular organisms. It may require extensive treatment. That is the property shared with Brucella. Gentamicin and or streptomycin is one choice, together with doxycycline or ciprofloxacin as alternative or prophylactic treatment. If you suspect exposure, that's what one would take as a precautionary measure. Again, don't put too much emphasis, don't memorize those treatments. I'm not going to ask you what is the treatment for which of the infections, because I do realize, as I pointed out, these antibiotics of choice may change by the time you're going to practice medicine. Before the last outbreak of anthrax, penicillin was supposed to be quite effective. But when there was an outbreak, Cipro became the word of mouth, really. I mean, everybody knew the word Cipro because of the press, and that's the antibiotic that was used. So I don't put too much emphasis on memorizing what is the antibiotic you're going to use. If I do ask, it will be in context with, the veneer, to give you some idea, okay? That doesn't mean that in the exam or quiz there won't be any question, in the exam particularly on antibiotics, mechanism of action, how they act, the things that Dr. Mayer talked about, because that has not changed, and it's not likely to change, the mechanism of action. Yeah?
So you're just saying that you will not ask what antibiotic...
It will not be one of the foils that this antibiotic is the, choice of treatment, because that, I don't think that's important really for you to memorize now, because it's likely to change. Prevention. If you think that there have been cases of tularemia in a certain area and you do go hunting, wear gloves and, to handle the animals and take regular, ordinary precautions. That it would be prevention. Okay? And the other thing is that since it can be transmitted by ticks, one uses insect repellents or avoids the tick bites whatever way one can. So that was the tularemia. And we come back to the same thing. Again, the case that was reported in one of the journals That happened, I think, somewhere in Tennessee. Okay, comes GR, lymphadenopathy, headache, muscle ache, physical and real cellulitis, important thing, lymphadenopathy, cellulitis. She was treated with cephalosporin, a beta-lactam antibiotic for cellulitis of unknown etiology. The treatment was ineffective because, remember, it is difficult to treat and it has to be prolonged treatment. And she was treated for just any other general infectious cellulitis. And it was cephalosporin rather than ciprofloxacin. Okay, it was ineffective. She returned to her primary care physician, who discovered that she had a hobby of sewing together tan rabbit hides. You've seen that before. That's why it's important to know the patient. The family practitioners, you know, if you're in family practice, it is very good to know the patient, what they have been doing, what they like to do. It does sometimes help in providing better care. Had a hobby of sewing together tan skin hides to make blankets, and she recently had skinned a rabbit and tanned the fur. Okay? And that gives you a lot of those clues to what organism it might be that is causing the cellulitis. And you would not treat for general cellulitis, you will suspect tularemia. Okay, obviously it's not the Staph aureus, it's not, Staph aureus is not gram-negative, it's gram-positive, Brucella abortus, it's not Brucella abortus either because there is no ulceration in the case of Brucella abortus, muscle aches, yes, Listeria monocytogenes, we'll talk about later on, it is obvious, it is not that either. It's not Bacillus anthracis, you will see the differential in a minute, and it is Francisella tularensis. And once you know Francisella tularensis is the organism, think of what might be the pathogenic mechanism. Okay? And in this case, the pathogenic mechanism is the capsule. It's a capsulated organism, and the capsule, Dr. Fox spelled it out, and he emphasized, remember, capsule equates to resistance to phagocytosis and intracellular killing, okay? Antiphagocytic. Most capsules are, actually almost all of them, are antiphagocytic. So it can persist there, it can survive intracellularly. Intracellular organism equates to, in terms of immune response, what? Come on. Come on now. Exam is very close. Cell-mediated immunity. Cell-mediated immunity, lymphadenitis, and, all of those cytokines that are being released will cause the symptoms. Okay? Cytokines, including interferon gamma. Why do you think you get such lousy feeling after a virus infection? Because interferons, okay? Interferons are inflammatory and they produce side effects. While they protect you, they also produce a lot of side effects that makes you feel lousy. I know somebody who was undergoing interferon treatment, and he thought, well, his word, not mine, he felt like shit every day. Okay? He would rather have hepatitis C than interferon, sometimes he thought. Yes?
Why would you go under interferon?
I'm sorry?
Why would you go under interferon?
Because hepatitis C, when Dr. Mahant comes, she will tell you that hepatitis C, the latest treatment and most effective, and even that is no more than 40 to 50% of the cases can be treated, is interferon. No. Interferon stimulates the immune system. Remember, interferons are good activators of NK cells and phagocytes. They increase the MHC, and therefore the more cell-mediated cytotoxicity. So interferons are used for certain viral infections, and that is hepatitis C, and also in malignancies, which we talked about. Okay? That's why interferons are used. All right, we are coming to the next one. This is fictitious, not reported, but similar cases have been reported, and I'll show you an example of that probably. A 35-year-old man is brought to ER by an immigrant officer with a history of chills and fever. The patient was apprehended from a ship which had docked in many Asian and African ports, and the patient was allegedly being smuggled into the country. The INS officer described the appalling conditions on the ship, infested with rats, and many of those rats were found dead. Physical examination revealed dark, enlarged inguinal lymph node and splenomegaly. Memorize that, the underlined phrase. Okay? Because that clearly points to a certain organism. Okay, skin around the lymph node had purpuric lesions. That again is an important clue. Culture of the lymph node aspirate at 28 degrees. Usually organisms are, most of them are cultured at 37. That's right, and body temperature is 37, okay? Except the skin that is exposed to outside. Therefore, this organism will tend to be superficial, at least in the early growth times. Okay, culture of lymph node at aspirate 37 yielded gram-negative cocobacilli. The organism is most likely to. That's the first thing you have got to recognize what the organism is. Yersinia pestis, it could be. The other choice is Brucella abortus, lymphadenopathy. Okay? But their lymphadenopathy did not have this darkening of the or hemorrhage around the lymph node, and those were not just superficial lymph nodes. Listeria monocytogenes, intercellular organism, that can also, since it's intercellular, it will induce cell-mediated immunity. It could also induce lymphadenopathy in some cases. Bacillus anthracis, superficial lesions, okay? And Francisella tularensis. No, obviously it's not Francisella tularensis because you saw some of the associations with that. History was very, very important. Okay, so let's see what the organism is when we have finished with talking about Yersinia pestis. Okay, Dr. Yersin is the discoverer of these organisms. You'll see that later. There are three organisms in that are have significance as far as human health is concerned, and most serious, most important one is Yersinia pestis. That causes plague. Enterocolitica, I think Dr. Fox talked about that. Okay. Cold countries, Norway, Sweden, in Scandinavian countries, the organism survives at the cold temperature. Okay? And pseudotuberculosis, it is a related organism that causes minor health problems. I'm going to spend most of the time with Yersinia pestis because that is the most serious infective agent. So much so that plague has claimed millions of lives, and this was the almost wiped out most of the population, or a quarter of the population in Europe in one of the centuries. Yes, 14th century. Okay? So it is a very, very lethal infection. In 1890s, 10 million in Asia. When I was growing up, I grew up my parents lived in a small village in India. I was born there. And growing up, I remember the sort of, the tales that you can hear from different people. If dead rats were found around the house, people panicked, because they did associate it with plague. Are you likely to see the cases? Maybe not, but there are. It is indigent in southwestern parts of the United States. Okay, mostly in the reservoir of different animals, and we'll talk about that in a minute. Historically, as I said, it was discovered in 1894 by Dr. Yersin. That's why the name Yersinia. Most cases are sylvatic. There's a sylvatic and plague, and there's bubonic plague. And bubonic plague is in the humans, whereas sylvatic refers to the animals. Okay, about 400 cases have been reported in the southwestern, and they are reported almost every year in that number. There are occasional human cases as well. Last 2-3 weeks ago, MMWR reported 4 cases, one after the other, in the same, within few weeks apart, and one of them was lethal. The occasional bubonic, urban plagues, that's where this term comes, buboes, B-U-B-O, buboes, and we'll see what the buboes are. If one looks at the human plague situation, look at the incidence, the numbers from 73 all the way to 2003, prairie dogs and rock squirrels had a lot of infected cases and spilled over into humans. How the human get the infection, we'll see it in a minute. If you look at the 01 to 06 cases, there are 2, 1 to 3, 7 or 8, and this year already 7 cases of human plague. Okay, here is the one that is very recent one. Oh, no, that's not the recent one, actually. That's about 2-3 years ago in New York, and that's the real one. Case number 1, on November 5, a man of 53-year-old sought medical care in New York City Emergency Department with a 2-day history of fever, fatigue, and painful unilateral inguinal swelling. Unilateral inguinal swelling. Very, very important clue. Okay? He appeared ill with diaphoresis, rigor, and don't ask me what diaphoresis means. I didn't look up. Sweating. Okay, good. Thank you. Rigor, shaking with chills, and lower extremity cyanosis. His temperature was 104, high temperature, 42 if you're more familiar with centigrade. Blood pressure was 78/50, low, and oxygen saturation was 98% on room air. He had tender left inguinal adenopathy with overlying edema, another clue to Yersinia infection. White blood cells was 24,000 over 24,000, normal is 4 to 10, and platelet count was high, low, very low. A blood culture grew Yersinia pestis, gram stain of the culture isolate revealed a bipolar. They are sometimes referred to as safety pin-like appearance. Okay? So you will see some pictures, I think, later on. Bipolar gram-negative rods with safety pin appearance. Oh, here it is. Okay, the patient received gentamicin, doxycycline, ciprofloxacin, vancomycin, and activated protein C for low thrombocytes. The patient condition deteriorated, and he was admitted in intensive care in shock with a diagnosis of septicemic plague. Acute renal failure, acute respiratory distress syndrome, and disseminated intravascular coagulation. That's one of the pathogenic mechanisms, coagulation. He required hemodialysis and mechanical ventilation, and underwent bilateral foot amputation subsequently because of ischemia. After 6 weeks ICU stay, he recovered and was discharged to a long-term care rehabilitation facility. That happened in New York. Well, if there are 6 or 10 cases only in the nation, why should you worry about it? The reason is you don't know that you're going to get those 60 cases. If you get common cold, common diarrhea, common infections, you're going to see enough to get experience that you will treat it. But what if you don't recognize the rare ones? And that's why I emphasize, actually, they say, okay, be familiar with the rare ones so that at least you can suspect or you can consult somebody. Yes?
How long was the infection until?
I'm sorry?
How long was it before, after the exposure?
It's week to 10 days. Yeah, the lymphadenopathy will start. Okay? But it can be treated early on. That's what is the thing, that if you diagnose early, you can treat it and save lives. The wife also had plague, but without complications like ischemic limb damage. So they both were exposed. Where did they come from? New Mexico, right? No. They were visiting, actually, from where? Does it say here anywhere? No. They were from New Mexico visiting New York. Most of the cases are seen in. Okay, case 2 this year, actually. No, that's last year, I think. That's last year. All right, this year it has not arrived in November. Wife of a 47-year-old patient, patient 1, also became ill. Oh, no, this is his wife, I guess. It's the, okay, let's see. She brought medical care for fever, fatigue, myalgia, unilateral inguinal swelling. Again, that's the key point. Just go ahead and read on, and I'll just point to the lymphadenopathy, another sign. Low blood pressure. Okay. Aspiration of inguinal lymph node did not yield any material. The patient received presumptive diagnosis of bubonic plague because of her clinical signs and symptoms, and the recovery of Yersinia pestis from, oh, this is the wife. Okay, I have left that. I thought I had removed that one. All right, morphology is gram-negative organism. There were 4 cases this year, actually, reported. One in February, one thereabouts. Okay, it's a gram-negative, pleomorphic, means many forms. Bacillus doesn't, this is an aspirate, of course, from the lymph node. As you can see, some white cells there. Facultative anaerobe, meaning that it can grow in anaerobic conditions. It's not an anaerobe, but a facultative anaerobe. It has the faculty to grow in anaerobic conditions. Optimal growth is at 28 degrees instead of 37. That's why the superficial inguinal and the axillary lymph nodes are often involved. I've already said that it's facultative intracellular facultative anaerobe as well as facultative intracellular, because it can survive within the cells intracellularly. And intracellular meaning that it will stimulate cell-mediated immunity. Here's a sort of faint, presence of organism there. Okay. Life cycle is from fleas to rodents. Okay. Most commonly, rodents are involved. mass of plaque bacteria form in the gut of infected fleas, and as they take blood meal, they regurgitate uncapsulated organisms into bite of an animal or human. Uncapsulated. In the flea, it is uncapsulated. Okay? That's an important, very typical characteristic of the organism. Whereas when they are injected, when they enter an animal tissue, they start encapsulating. There are certain virulence factors that help them become encapsulated. Most organisms are destroyed by PMNs because they are not encapsulated, and they can be phagocytized, and they can be destroyed. They can be killed. But a few survive, particularly in histiocytes, as they enter histiocytes. Bacteria re-encapsulate and grow, causing all the symptoms. The progeny is resistant to intracellular killing because now they are encapsulated. Okay, the different forms I already told you about. Sylvatic is in animals, rodents, rabbits, other carnivores. The mode of transmission again leads to animals. Bubonic, flea bites from rats or other infected animals. Humans are bitten and they develop bubonic plagues. Pneumonic plague is from person to person. Okay. Bubonic plague is slow progressing, and ultimately it is going to go and become bloodborne, enter the lungs, and from coughing or exhalation, it is going to be transmitted to other humans. And that is what pneumonic plague refers to. So it can be transmitted from human to human. The pneumonic plague. Pneumonic plague is most dangerous. Within a couple of days, there can be a death. So usually, whenever there is a case of bubonic plague, the recommendations are quarantine. The individuals with bubonic plague are quarantined. And every precaution is taken. There's a lot of precaution taken when the samples are sent to the laboratories. Okay, symptoms of bubonic, you have already seen those in those two cases. Sudden onset of headache, malaise, myalgia, fever, tender lymph nodes, draining lymph nodes to become hot, swollen, hemorrhagic, and painful. Those are referred to as buboes. I wonder if the term boo-boo comes from that too, that we tell our children. Okay, here is the under the arm. No, that's not under the arm. That's inguinal. Okay, I think. No, that's under the arm. There's the head. Okay. Oh, it is the shadow of the finger. It is inguinal. The anatomy is, my anatomy is not very good. Okay. Cutaneous findings, possible papules around the flea bite, vesicles or pustules at inoculation site, purpuric lesions appear later on, and those are around the either bite or around buboes as well. Here's another one. Okay, septicemia, an invasion of lung, will lead to pneumonia. And that is the stage when the infected individuals can transmit other humans. Symptoms, we know when the spreading from between the lymph nodes, local infection to the lungs. They will obviously be septicemic stage, the blood stage, and it is referred to as septicemic form. And septicemia, an invasion of the lung, pneumonia, we already covered that. Circulating organisms can cause subcutaneous hemorrhage and black death. It is also referred to as black death. Yes?
I thought it grows at 28 degrees.
Yes, but then when the organisms become very diffuse, a lot of them, they are going to go into other. Grows best at 28 degrees. It's not going to get killed, at 37. It just grows best at 28 degrees. Okay. Exhaled organisms infect others, causing pneumonic plague. That's repetition, which is not always bad. The acquired it is acquired to person, obviously, pneumonic plague. Prodromal symptoms are flu-like. Okay? Rapid progression to hemoptysis, spitting blood, because it's very, very rapidly destroying the lung tissues. Not only that, remember, it inhibits coagulation. Okay? So they will be bleeding. Often bilateral, infiltrate, and rapid death within 1 to 3 days of acquiring pneumonic. Okay, in this case it's not bilateral, but it is often bilateral. Okay, now this is the 4 cases. I probably don't have all 4 cases there, but this is the one of the 4 cases that was reported this year. On May 17, a woman aged 54 from Bernalillo, I think somewhere in California, New Mexico, it says here. Okay, went to a local urgent care center with a 4-day history of fever, severe abdominal pain, bloody stool, no lymphadenopathy was noted. There can be atypical cases. Now, since it is in that area, that may be the only clue, at least so far. While being evaluated, the patient began vomiting blood and experienced acute respiratory distress. She was transferred to regional hospital but died within a few hours of arrival. Blood and lung cultures obtained on autopsy yielded Yersinia pestis. So you can't help everybody. And as you can see, within a day or 1 to 4 days, within 4 days. Okay, blood, Yersinia pestis. However, no histologic evidence of plague pneumonia was discovered. One of the patient's dogs and a rock squirrel that had been trapped by investigators on her property had serologic evidence of past infections with Yersinia pestis. So from animal, particularly some animal that is so close to the human, you can get either through ingestion or inhalation. In this case, obviously, it was ingestion, and from there it is spread to the lung. Okay? That's a very atypical case. Another one on May 25, a man aged 45 years, Santa Fe County, again New Mexico, hospitalized, 4-day history of high fever, vomiting, nausea. Radiographs revealed lower right lobe infiltrate. He was admitted with a diagnosis of pneumonia. Obviously, that's what you will think first. The patient was treated with gentamicin, but was not placed in respiratory isolation. On hospital day 1, the patient required intubation for respiratory distress. On day 2, blood cultures drawn yielded Yersinia pestis. The patient remained on mechanical ventilation for 4 weeks and eventually recovered. At least 37 hospital workers had contact with the patient. Obviously, they did not realize it was Yersinia pestis, and he was not quarantined And normally I would imagine that a lot fewer people will be allowed to come in contact. Both of patients' dogs had serologic evidence of past Yersinia pestis infection. It was isolated from 2 fleas, come from wood rat. Okay, this is almost like criminal investigations. The epidemiologists and CDC people, they are experts in those things. Once they see an infection, they go to the root of the infection, where they try to trace where it came from. Okay, so that's another atypical case. And so I have showed you typical as well as atypical cases here. Virulence determinants, calcium dependence, okay, LCR. That is a trait that allows the expression of those genes, allows for the organisms to grow in low calcium environment. Okay, protein V and W. Okay, those are the other 2 proteins. I will talk about that later. YOPS, Yersinia outer membrane proteins, it stands for, and there are several of those. Envelope F1 antigen, that is the capsular antigen or capsule. Coagulase and fibrinogen activator, fibrinolysin. Okay? And those are involved in spreading, the breaking of the clots and spreading through the body. VW, plasmid encoded protein, you don't have to memorize that. I'm not going to ask. Part of low calcium regulated response. And it gives the organism's ability to rapidly proliferate and very, very rapid septicemia. As you saw, that it progresses within a few days to cause death. Yersinia, I'm not going to expect you to memorize all 11 of them. Just, remember that they are responsible for cytotoxicity. In other words, infected cells get killed, and the organisms come out and infect other cells. They inhibit phagocyte migration, engulfment, and intracellular killing. So there's a lot of ways that the organisms can escape host defense mechanisms, the non-specific immune system that is responsible for early protection. Inhibits platelet aggregation, and therefore those you saw the hemorrhage around the buboes. F1 antigen, protein polysaccharide complex. Normally capsules, as Dr. Mayer told you, there are polysaccharides. There are some exceptions. This is one of them. It's a protein polysaccharide complex. Highly expressed in mammalian host. So when the flea has the organism, they do not have capsule. And that's what I was telling you earlier, that after infections, most of the organisms are killed. But a few can survive in histiocytes, particularly that are not as effective in killing intracellular organisms, and now they start expressing F1 antigen in that environment. It is not expressed in flea host, it's anti-phagocytic. And therefore the organisms are protected. Antibodies to F1 are protective. So if you have antibodies to that and the organisms come out of the cell or they are extracellular, they can be killed by antibodies. Plasminogen activator, fibrinolysin, and coagulase are also plasmid coated, and they are involved in dissemination of the organism from the clots. Fibrinolysin leads to C3b and C5a. degradation. Therefore, what is C3b is involved? It's an opsonin. Remember, it's an opsonin. Okay, if they are degraded very quickly by the organism, then you are not going to get a very effective phagocytosis. And C5a is involved in chemotaxis, attraction of neutrophils and phagocytic cells to the site. Not only that, but once it interacts with phagocytes, they are activated to have more efficient respiratory burst and therefore intercellular killing. So there's another way it compromises the host's immune system. Diagnosis: physical examination of buboes, aspirate or blood, sputum, or other fluids as indicated. Okay? By what one does, takes the aspirate of a bubo, put it on a slide, fix it, and stain it, and look for the characteristic bipolar staining organisms. If you look at carefully, to me that is very characteristic safety pin appearance. Fluorescent antibody tests, they are standard known anti-Yersinia pestis antibodies as reagents, and one can use those on the slide, and organisms, of course, will glow with that. Culture identity, when it can culture, but it is hazardous. If one can avoid culturing and diagnose without culturing, that's best, because you're putting at risk the lab personnel as well. They have got to be especially trained to handle this organism. Treatment: hospitalization and strict isolation, quarantine, extreme precaution, mask, gloves, etc. Streptomycin, tetracycline, ciprofloxacin, or doxycycline are the antibiotics that are used. Minimize domestic rat population or other population. Be careful, dogs not avoid, keep them away from fleas, or keep fleas away from them. Control of flea population. Those are the precautions. Okay, so that is all about Yersinia pestis. Now, if you really look at it, the conditions here: dead rats, okay, infested with rats, many found dead. It's not very common in this country, but there are other countries that they have got hot spots of Yersinia pestis, in the wild population among the fleas and rats. And okay, the dark and large inguinal lymph node and splenomegaly gives you a clue. Isolate, yielded. It is grown at 28 degrees centigrade in the lab. So when you send it, the lab knows that you're suspecting Yersinia, they are not going to put it in the 37 degrees centigrade. They are going to grow it at 28. They will know once you indicate it could be Yersinia pestis. Well, Brucella abortus, that obviously we can exclude now. Knowing Listeria, we do not know much about. We can't exclude that. Bacillus anthracis, we'll see how we can exclude that one. And Francisella tularensis, we can very easily exclude that one. The history is different. The pupil is different. Okay. The discoloring is different. It's darkened rather than the bluish halo around the lymph node. No eschar in this case. Okay. So that's how we can exclude that. We'll take a break here and finish off with a couple of organisms here. Okay. Unfortunately, there is a lot of memorization. But when you really think of it, once you know the organism and you know what the pathogenic mechanisms are, then you know why the symptoms occur.